Good afternoon. I'm Nicola Jones. I'm a GP and I'm chair of Wandsworth CCG. And I've got to do the usual stuff today, tell you about, first of all, that we're not expecting a fire alarm. And so if you hear one, then please would you vacate the building through a fire exit there or through the entrance that you came in. And for those of you who didn't manage to get down to the rooms at the end earlier, there is, if you just go along this corridor after the meeting, there's some market stalls where we've got lots of local services and lots of information there. So if you haven't been in there already, then please do after the next hour is over. So I wanted to welcome you all to our annual general meeting. This is the meeting in which we report on the work that the CCG has done in the last year. That's the 16-17 work. So in the next hour or so, you're going to hear from several members of the CCG team. You'll hear from our Chief Finance Officer, and he's going to report on how we've managed the money that we've been allocated. That's important because we all contribute to that money, and so we want to make sure that it's being spent wisely. You'll also hear from our accountable officer and from our managing director, who'll explain how we met our responsibilities in that year and where we succeeded and where we still have work to do. And then we're going to hear from some of our clinical leaders, our GPs, who are going to describe some of the work that we've done that's making a difference to patient care and to people's lives. And then we'll hear about the year ahead and the inevitable challenges that we face and our plans. And then there'll be some time for questions at the end. So it's going to be a busy hour, and if it doesn't go to plan, and if my speakers don't keep to time, then it might look like a busy day at Clapham Junction. But if it goes well, then I hope that what you'll have is a sense of the massive amount of work that we've done in the CCG over the last year. So I'm going to hand over, first of all, to James Murray, who's our Chief Finance Officer.
Right, good afternoon, everybody. So I'm James Murray, the Interim Chief Finance Officer for South West London Alliance. So I sit across 4 CCGs, including Wandsworth, Merton and Kingston and Richmond. I wasn't actually here last year, so all the credit goes to other people in this room who have delivered what was a strong financial position. But I'll give you a summary of how we got on. So in terms of funding for 2016-17, we're funding on a national formula basis. It takes into account our population in terms of how many people live within the area and are registered with our GPs. And it also takes into account the age profile of that population, gender, morbidity, and also the cost of running services within South West London. So that's how that's calculated. We've got our population numbers there. So last year we received £481 million within Wandsworth CCG, which is equivalent to £1,500 per person. Clearly we don't spend it like that. As we go through life, we tend to absorb more resources when we're born and more resources as we get older. So if you look at the sort of profile, it tends to go in that sort of graph shape when you look at how we spend our allocation across the population. And to the credit of the CCG, because we all read stories about how challenging the financial position is for the NHS nationally, it's in the press on a regular basis. It generated a surplus in line with its targets of 6.6 million last year. So that's its target to deliver that, and that was fully achieved. So that's credit to the not just the finance team, but the CCG as a whole, that it managed to do that. In terms of financial targets, they're listed there. We have to maintain financial stability, which we've done, and has set us well for this year as well on an ongoing basis. We have a value for money test, so our auditors take a view of have we used the money in the most fair and effective use of resources, and we got a tick for that. We have the mental health parity of esteem, so have we kept up with investments on mental health, which again we're in line with our growth allocation, which we've managed to do. And also we have a limit on how much we can spend on management costs, which is calculated on a head per population. And again, we achieved that. So we've got a good clear run on all of that. And again, to the credit of Neil, who's sitting quietly at the back, and our finance team, our accounts were submitted on time, and we got an unqualified opinion from our auditors. So that's all to their credit. Just to give you an idea of how we spend the money in terms of the proportion of that, What we don't do, I guess it's worth just mentioning the things we don't commission. So we don't commission specialist services. So for renal cancer and some other specialist services, they're not within our commissioning portfolio. And also there are some public health type services which have now moved across with public health to the local authority. But from what directly the CCG sort of commissions, there's the split of how that gets spent. 48% of that, as you can see, goes into hospital services, and that's run through sort of standard NHS contracts, and that's how that's managed. We spend 22% directly on delivering our primary care services in terms of what that provides to the community of Wandsworth. And then you can see also the other big spend on there is our mental health and community services, where we spend about 132 million a year. And I say, despite all the challenges and the cost pressures, we did manage to deliver our financial targets for this year. Okay, I'll hand you over. Any questions I can take at the end?
Okay, so I'll start and do a double act with Sarah in terms of talking about just a little bit of a summary of the year. So just set out on the screen here are the strategic priorities that really drive the CCG to look at the transformation of services and the sort of values and the sort of ways that we look to work really as a CCG when we're taking forward the redesign of services. So really three key principles around prevention, integration and collaboration. So really in terms of the prevention agenda, it's about saying how do we ensure that instead of managing people when they get particularly ill, when they need hospital treatment, that we identify the causes of ill health, that we identify people with long-term conditions, and that we get the right support around people in order to make sure that they're effectively supported to remain well and independent and in the most appropriate setting closest to home. And I think some of the examples and case studies that we'll hear later will take you through how, on a very practical level, we've been doing that in terms of some of the services, not just the ones that we put in place in 2016-17, but also really significantly expanded some of the new and changed service models that are fairly unique to Wandsworth, actually, to make sure that we can do that for large numbers of our residents. Integration is also absolutely key. So what we're looking for within health and social care services is to ensure that the experience that service users have of health and care is absolutely seamless, and that the boundaries between organisations are not the defining feature of the sort of experience of care that people have. And we know that services work most effectively when they work really closely together. So one of the great features of 2016-17 was the institution of the multi-specialty community provider contract, which has been awarded to an organisation called Battersea Healthcare Community Interest Company. And that's a contract that really allows us to bring together community and primary care services in a much more effective way. So effective of next month, the Battersea Healthcare, who are a GP Federation organisation, so they're representative of all of our GP practices, will be taking the leadership for the delivery of adult community services, working with Central London Community Healthcare as their subcontractor. So that's really about making sure that those community services, so district nursing, etc., are extremely well integrated with primary care services, and that we get a really integrated offer. And the next stage is really picking up on the collaboration to then work on, we've already taken significant strides in terms of the integration of community and social services, so really making sure that we bring all of it together. And part of that work is on a Wandsworth basis, but also that's about then beginning to look at the Wandsworth and Merton footprint, which is the basis on which I and many of the executive team and managers here now work, because we work as a single team across Wandsworth and Merton to say, how do we integrate community and social primary care in both boroughs, but also bring together the acute hospital into that picture as well. So how can we start to get acute clinicians, acute consultants working out in some of our community and primary care services to make sure that instead of a patient, in a sense, sitting with primary care and then being referred and sitting with acute care and then being discharged back, that actually it's a single integrated team. and some of the work that we've been doing around diabetes is really critical to that. So getting specialist nurses and consultants from the hospital to work really closely with primary care to support patients with diabetes, because diabetes is a lifelong condition, and we know that people need ongoing and continual support. And sometimes the model that traditionally we've had, where a patient is with primary care until they're referred to a specialist diabetes service, might not be the most appropriate model. What we actually need is a mix of primary, generalist and secondary specialist care throughout a patient, the management of a patient's condition. Main challenges that we face. So I just want, obviously it will be worth me mentioning one of the main challenges, which has been around some of the challenges that St George's have had around both their performance and their delivery of key standards, but also around some of their data and making sure that they're able to appropriately and accurately report on some of their standards at the moment. So obviously many of those issues came to light for St George's during the 2016-17 year. We've also recently been working with them on some very similar issues at Queen Mary's Hospital in Roehampton as well. I think what's absolutely critical for us is that we work to safeguard the patient experience through this, so we know that in many areas St George's continue to provide a really high quality clinical service. Equally, we know that the waiting times at St George's at the moment do actually affect the patient experience, and we need to make sure that where that waiting time was so significant that it affects the quality of care, that we make other options available to patients. So we've been working hard with GPs in Wandsworth to make sure that they're aware of other referral routes, other options for patients, and to make sure that we've got appropriate provision in where at the moment St George's needs some support in terms of the volumes of patients who've been referred in. And also we've been working really closely with the GPs to ensure that our quality alert system called Make a Difference works well. So where we have where a GP becomes aware that a patient has waited a very long time at St George's, they're able to make an alert to the CCG, and we're able to follow up with St George's and make sure that where there is any issues around the patient's sort of clinical safety and quality due to that wait, that we get those addressed straight away. So really challenging issues at St George's, but I think the CCG's played a critical and important role in terms of making sure we manage them, and we continue to work with St George's on that. Okay, Sarah, thank you.
So thank you, James. So my name's Sarah Blow. I'm the Accountable Officer for the South West London Alliance. So like James Murray, I am the Accountable Officer for Kingston, Richmond, Merton and Wandsworth, and from April next year also Sutton. And it's really fantastic to be here and see so much engagement actually from the public in Wandsworth, and that's what I've noticed about Wandsworth CCG over the last few months since I've been here, is that number one, there's a real strength of kind of community and engagement with the local population, and number two, really strong clinical leadership from the CCG, and that clinicians are at the forefront of everything that happens in Wandsworth CCG. So that's kind of really positive for me as Accountable Officer. What I have to do now is talk to you about the formal part of the annual general meeting. It's my first annual general meeting, and I can take no credit for the work that has happened in the past year. And you have a fantastic team here and have done for a number of years. And obviously the governing body and the clinical leads take all the credit for the work that has been done in Wandsworth. So I'm going to do a bit of a reflection of some of the things that have happened in Wandsworth in the last 12 months. And then a bit later on, I'm going to have a bit of a forward look. And then we're going to, as Nicola said, we'll have some clinicians talking in between about some of the work that's been happening. So you've got some of the performance indicators here that show that we do have a national requirement as a CCG to meet a number of performance indicators, quite a lot actually, and I'm sure that we do measure those quite well in the NHS. But they are good indicators because they do, and I'm going to talk about some of them, they do tell us whether or not we are achieving good outcomes for our patients. You have to pick an indicator, but actually all of these lead to good care for our local populations. So some of the ones that we've performed really well on are particularly around early diagnosis. It's really important that we diagnose patients early for a number of different reasons, and we have national targets around that. So dementia is a good one. We have a national target. We say that they do a calculation nationally where they say there's a prevalence in your local area, you should have so many people that you're diagnosing with dementia. It's really important that we try and hit that, because if we don't, it means that people out there who have early onset or starting to experience some symptoms of dementia won't get the kind of support that they need to help them for the future. So those kind of indicators are really important to us, and Wandsworth did incredibly well on those. Psychological therapies, again, that's about people gaining access to some support before they become very ill, around some mental health support, those with anxiety, maybe simply depression. And we achieve really well on some of these indicators. You will all understand the need to diagnose cancer early, and we have some really good outcomes as well across South West London actually on cancer, but around early diagnosis in Wandsworth. Some of the areas we don't do quite so well, and people may disagree that the A&E standard, which is that you need to be seen within 4 hours and treated when you go to A&E, is a good or a bad target. My view is that it is a really good indicator of what's going on in the whole system. If you're seen quickly in A&E and you are admitted quickly because you need to be admitted, what that means is that you are being seen quickly. It means you're getting the medical support that you need. It means the bed is available for you, and that means that people are being discharged from that hospital appropriately. And it also means that you're getting the right support in the community, because we haven't got lots of people in A&E that don't need to be there. So these are really good indicators of the whole system. We haven't quite reached that in Wandsworth for A&E, but I would say this is a really difficult target nationally. 91.6% is not achieving the target, but I would hope that we could improve that, although we are all concerned that as we go into winter, we're seeing more demand in our local A&E departments, and this needs to be a focus for all of us. I'm going to try and work the IT. Oh, that's good. So that works. So because we had such good outcomes from some of our indicators, and they look at lots of things when they look at CCGs. It's not just about some of the outcome indicators. It is, did we manage the money? You know, have we got the right leadership in place? Are we delivering the right services for our local populations? So they look at all of those things, and then they mark us. I think there's something like 57 indicators, and then they mark us and they say you're good or you're not assured. And Wandsworth CCG is good, and that's a fantastic outcome. So based on all the work that's been done locally for last year, the CCG was seen by our regulators as good, and that's an excellent outcome for us. And we've got a lot of strong performance, and I've already talked about some of those. And I think that we do need to congratulate the team that was here before, but there's always more to be done. We aren't achieving on some indicators, and we're always striving to achieve the best outcomes for the local population. So there's lots of work going on currently to look at those areas that I had already identified, and particularly around things like psychological therapies. One of our areas is around recovery. So we do refer lots of people into the service, and we've got the right number of people going in, but they're not all recovering at the level that we would like. So we're working with the services to make sure that that happens for the future. So we're always striving to improve our services. So I'm going to talk a bit later about the future, but I'm just going to ask James just to talk a little bit about the risks that we're now facing as we go forwards, and then we will hear from some of the clinicians.
So just I think some of the challenges that the Wandsworth CCG is facing going into this 17-18 year, and that we're tackling at the moment. So from a strategic planning perspective, one of the recurrent trends that's facing the NHS at the moment is continuing demand growth. So we know in a sort of broader strategic context that Sarah will talk about later, that in the Wandsworth and Merton area that I work across over the next 9 years, the number of elderly people will grow at 3 times the rate of working age people. And as James said earlier, we know that the use of resources in the healthcare system falls mainly at the start of life and during old age. So when we say that it's continuing demand growth against a fixed amount of capacity, we're talking about the physical capacity of services, we're talking about the workforce, and we're also talking about the funding available. So so the health service is nationally dealing with continuing demand growth from demographic change against a budget that isn't growing at the same rate. From a strategic perspective, I talked earlier about collaboration, and that's absolutely critical to us. So we now collaborate with a number of different organisations on a number of different footprints. So at borough level, we'll work together with our social care partners, with many partners in the voluntary and community sector as well. But across the across Wandsworth and Merton, we work together, particularly on issues around St George's, and then across South West London, we work together around issues that are more strategic as well. From a governance perspective, we're undergoing a number of changes at the moment as an organisation. So we are putting in place the structures and processes and systems that allow us to do more of this joint work. So we're currently engaging with our membership on changes to our constitution as a CCG that will allow us to hold many of our committee meetings together with other CCGs. So across Wandsworth and Merton, we will regularly hold parts of our finance and quality committees together because as Wandsworth and Merton, we face a number of the same providers and a number of the same issues, particularly around quality and particularly around St George's. But also for some of the commissioning work we're now doing that on a South West London basis. And so we will be holding some committee meetings together across South West London in order to, for example, look at where commissioning policies might change so that we get a consistency of approach across a wider footprint. In terms of operational performance, you will hear, if you come to our boards quite frequently, us talk about QUIP, which is quality, innovation, productivity and prevention. What this is really shorthand for is the work that we do in order to every year address that gap between the growth and demand that we see as healthcare commissioners and the finite resources that we have. So every year we're always putting in place initiatives that mean that we can effectively do more to meet that growing demand within the resources that we have. So delivering that plan this year is the most challenging it's ever been for Wandsworth, and it requires really close joint working with a number of agencies to deliver it. And obviously we'll continue to address the acute performance issues that we have been facing to date. Just probably worth just talking then about some of those risks. I think I've talked about most of them as we've talked through those various issues around finance and quality, around system performance, and addressing some of those measures where we didn't meet the standards expected in 16-17. I would also say that what's really important with this is it's a system going through a huge amount of change. Sarah will talk about some of the work that we're doing around the STP. So I think what's absolutely critical is that we also make sure that as a CCG team, we work on making sure we're taking everyone with us and that we retain a really strong sense of local engagement. And one of the things that I've really picked up joining the Wandsworth team is how important that engagement is to local people, how important it is to local stakeholders. So I see it as absolutely critical to my role that we keep those really strong links with organisations such as Healthwatch, with WCEN, with other partners within the borough, and that we make sure that as we develop, we do it together as a health and social care system with our partners.
Thank you very much, team. That's great. So in the next 20 minutes or so, we're just going to have a series of mini presentations from our clinicians, our GPs, about the kind of things that we're doing in Wandsworth which make a difference to our patients. And I'm going to kick off. I've just got two examples of how Wandsworth is achieving its vision of better care and a healthier future. So I wanted to start by talking about atrial fibrillation. This is a common condition. 4 or 5 people in every 100 who are over 65 will have this condition, whether they know it or not. And it's an irregular heartbeat, and its importance is that if untreated, it can cause a stroke. And strokes are very much feared by patients, and with good reason, because they can cause a huge burden of disability and death. So people with atrial fibrillation can have a medication which is very effective at preventing strokes. In the past, the only option, if you had atrial fibrillation, was for you to be referred by your GP to the local hospital to see a specialist who would consider whether you would benefit from the medication and then start it if necessary. There was often a long wait for that. So we thought that this wasn't good enough for our patients. And what we've done is we've started a programme of work to ensure that people in Wandsworth can get effective care much earlier. So now GPs across Wandsworth have been trained to start the medication, and you don't need to go to outpatients anymore. You can go to see your GP who can assess you, start the medication safely and continue to monitor it in your practice. So patients are getting faster treatment and we're preventing strokes. My second example is about general practice. So this is the bedrock of the NHS, of course, I would say that. Patients tell us all the time that getting an appointment with their GP is the most important thing to them. And we've worked really hard to make sure that GPs in Wandsworth are supported to be the best that they can be. We've invested as support in all sorts of different ways across general practice. And a recent national survey showed that patients rated their GP surgeries on opening hours in Wandsworth as top in London. So we came out top in London. 81% of patients said that they were satisfied with their GP surgery opening hours. So we also did extremely well on the other indicators. So general practice in Wandsworth really is amongst the best, and it's improving. We feel very ambitious for it. Caroline, do you want to go next?
Hi, I'm Caroline Scott. I'm a GP here in Wandsworth, and I also work for the CCG as the clinical lead for community services. Another group of patients that we have been making a difference to is our more frail or vulnerable patients, and that's through developing really specific services to support them. We call this PACT, Planning All Care Together, and this provides patients with a longer appointment with their named GP, at which they discuss what their current concerns are. And I'll tell you now, sometimes those are really different from what a GP might think they'll be. And then together, the patient and the GP make a care plan with agreed goals and actions to achieve these goals, both for the GP and the patient. The patient leaves that consultation with a printed copy of this care plan, which they can then share with anyone else who's involved in their care. Last year, we extended this scheme with the Enhanced Care Pathway, or ECP for short. This was a scheme that focused on the 500 most complex patients across the borough. These patients went through the same initial consultation, so their named GP co-producing a care plan, but this care plan was then shared with the patient's consent across a wider multidisciplinary team, which includes social services, community nurses, members from the mental health team, specialist nurses like diabetes nurses, a voluntary sector coordinator, and a consultant geriatrician. This team worked together to assist the patient to achieve the goals that they've set out. And if it's all right, I'd really love to share an example of this with you. I'm going to tell you now, this is not a picture of a patient, or not my patient, and also John is not his real name. But he's an 84-year-old gentleman who lives on his own. He's got a history of mental health problems and he's got no contact with his family. 2 years ago, he broke his lower leg. It was a really bad break and it needed what's called an external fixation frame to help it to mend. That's where a sort of metal frame is applied to the outside of the leg. Normally that stays on for a few months and it's then taken off. But unfortunately for John, after the death of a close friend of his mental health deteriorated and he developed agoraphobia and felt unable to leave the house. And this prevented him from going to any follow-up appointments and having the frame removed. He also developed symptoms of bladder cancer, but again felt unable to attend any hospital appointments to have treatment for this. He'd been offered medication and counselling, but had declined to have those as they again involved going out of the house. He was really struggling in terms of his personal care. He wasn't able to wash himself properly, he wasn't eating very well, and as a result of that, he developed a really nasty infection around the frame on his leg. After the ECP team got involved and had the wider discussion, the complex care team started visiting him regularly at home. With their encouragement, he agreed to start an antidepressant medication, and he was also referred to the local palliative care team, who arranged for a counsellor to come and visit him at home. The counsellor visited him weekly, and with their encouragement, he started to think about leaving the house. The voluntary services coordinator arranged for a befriender to make contact with John, and together they started to make short trips out to a local cafe, to the pub. The voluntary sector also arranged transport to help him get to the hospital to see the orthopaedic team and the urology team, and he was able to get the frame removed from his leg, and he's also started treatment for his bladder cancer. Social services arranged for a carer to come in 3 times a week to help him with his personal care, and the improvement in John's hygiene and the support of the community nurses has helped the infected wounds on his legs to heal. As a result of the enhanced care pathway, John has had an improvement in his mental health, he's leaving the house, he's had his leg frame removed, and he's started treatment for his bladder cancer. The team say they've seen an enormous improvement in how he is compared to their first visit, and John himself says that he feels 1,000 times better. Successes like this have really led to the decision to extend the service, and for this year we'll be looking to support 800 complex patients across the borough.
Hi there, my name is Dr. Owen Carter. I'm a local GP and I'm the cancer clinical lead for the CCG and the Macmillan GP as well. So what I wanted to talk to you about was the Macmillan Move More programme. So this was launched in December 2016 and it's provided by Enable Leisure and Culture, which is a division of the local council. And it's a joint initiative, partly funded by the Macmillan and by the CCG as well. What it does is it supports people living with and beyond cancer to become more active. We know that there are services out there already, but it's not tailored to patients with cancer specifically. And it's proven that taking part in physical activity during and after cancer treatment is not only safe, but it also has many long-term benefits as well. So these include reducing the consequences of treatment, such as fatigue, and the risk of developing other conditions such as osteoporosis or diabetes. For some cancers, there is a growing amount of evidence that increasing physical activity can reduce mortality rates, disease progression and recurrence. The service offers a one-to-one behavioural change sessions and motivational support for 12 months. Through these sessions, they signpost to appropriate local activities, and they also have cancer-specific exercise classes. Sessions are delivered by cancer and exercise specialists who have tailored support based on the patient's condition, treatment and motivation. So just in terms of the referrals that they're receiving, what this highlights, so people can see at the back, but basically is that if there's a range of both ages of when they're referred, at the time they're referred as well. So even before they receive active treatment for their cancer, then they can be part of the programme as well. So known to help in terms of the elements of the consequences of having treatment such as chemotherapy or radiotherapy. And there's a large different number of tumour sites. So it's a patients from large different types of cancers are taking on the programme. So 86% of participants who completed a 3-month assessment increased their physical activity levels, and 71% increased their quality of life scores, and 71% improved their fatigue status. The cancer-specific Move More class has been particularly popular, with 50% of referrals going on to attend those classes. And not only that, but they've signposted and supported participants to take part in a range of other activities, including local leisure centres and community classes. And they've also delivered programmes to local GP surgeries as well, for practice nurses and GPs, about understanding how physical activity and cancer fits. So I just wanted to just include just a few statements from a few patients about how this programme has been sort of impacted on them. So Move More have arranged membership for a local gym for me and given me both a fitness assessment and suggested a programme of exercise so that I can regain stamina, strength and then confidence as boat, having had chemotherapy in 2016. I feel that I've passed another milestone in that I've actually started exercise based on professional advice rather than just that I thought I ought to do so. I've made some substantial physical gains which have improved my morale. Encourages me to exercise, encourages me more to exercise bits that I wouldn't normally think about exercising, and motivates me to do more. It is helping me get my strength back in a controlled and structured way. And then finally, it's a great service. It's also good to speak to others post-treatment, to share experiences and encourage each other. Thank you.
I've just got one more kind of random bloke who just came in off the street. Dr. Coffey, would you like to?
Thank you. Yeah, I'm very random. I want to just talk about mental health and children. I'm the lead for both those areas. I want to give you kind of a few kind of snippets of what work we're doing in those two areas. On mental health, we've got a new service called Primary Care Plus. And what I'll try and do is tell you why have we done this. So lots of patients have an excellent experience in primary care. with mental health problems, some have a very poor experience. When patients are within the CMHT, secondary care, they're not always discharged back to their GP because there isn't a very good mental health infrastructure in general practice. So we've now started a new project whereby we're employing mental health workers to go into every single practice in Wandsworth. It's starting in the Wandle, and it started a few months ago, and they're seeing every single patient who's discharged from a CMHT, every single patient who's on a depot, every single patient who's on your serious mental illness register, and also taking referrals from general practice to bolster up mental health provision in general practice. Another project we're doing is exercise and mental health. What we spotted was that a lot of our patients with serious mental illness die early, not of their mental health issues, but of diabetes and cardiovascular disease. Secondly, what we spotted was that most people who can afford a personal trainer have it at 7 in the morning or 6 in the morning or 7 at night. And there's lots of personal trainers twiddling their thumbs between the hours of 10 and 4. So we've done a project which links in personal trainers being allocated to people with serious mental illness. And that's been going for the last 12 months. So patients with schizophrenia, serious depression, bipolar, are having 12 one-hour exercise programs with a personal trainer. A lot of people are very jealous of these people in Clapham Commons are going around with their personal trainer, and it's having an impact already on their physical well-being and their mental well-being. And that started this year. Thirdly, on mental health, I want to talk about the Crisis Cafe. So what we recognise is that patients can't plan their crisis when they're a mental health patient, and often when they're in a crisis, they don't know where to go, so they usually go to A&E. We looked in Aldershot, had this Crisis Cafe, a place open every day from 6 till midnight, 7 days a week, even Christmas Day, and it's got mental health workers working there, and it's got access to psychiatrists and CPNs. So in South West London, we decided to look at that model as well. And this year we opened our first Crisis Cafe in Wandsworth, next to Tooting Broadway Tube Station, and already it's getting really good input. And the idea is patients in crisis can attend there, and it reduces their need to go to A&E and get admitted. Further down the line this year, we've opened what's called a psychiatric decision unit. So if you've got a surgical problem, you go to the surgical assessment unit. If you've got a medical problem, you go to the medical assessment unit. If you've got a psychiatric problem, you wait there 24 hours in A&E. So we decided that probably wasn't the best for the patients. So now we've got a psychiatric decision unit based in Springfield, the first in London, trying to make sure patients who've got a psychiatric crisis and end up in A&E and may need admission are moved to this PDU, whereby they can be assessed by mental health professionals and hopefully discharged with support. Again, that's open now for about a year, and it has had a big impact on the reduction of patients attending A&E and being admitted. So we're doing a lot of work in mental health. I can see some of my mental health clinical reference group hopefully nodding. Nod, John, thank you. I'm not just telling you, white lies. So for children. So for children's services, again, an area which, the CCG focuses very frequently on. And we've tried to kind of make sure that our children's services, out of hospital particularly, are developing. So we work with an organisation called Place to Be, which is a counselling service for primary school children. It was in 11 schools in Wandsworth, now it's in 21 over the last 12 months. Secondly, there's a London quality standards for asthma in children. Asthma is the biggest killer of children over 28 days in Wandsworth. So we've invested in asthma clinical nurses, asthma consultant at St George's and outreach work to make sure we improve the asthma care and follow the London quality standards for asthma. Children looked after. The numbers in Wandsworth are growing quite significantly. Used to be about 170, now about 270, a big increase over the last 2 years. So we have invested in more children looked after staff to make sure their healthcare, their initial assessments, their regular assessments, regular reviews are done by highly qualified staff and followed through to make sure we're giving these most vulnerable children the best health start they can have. One area that people came to me and said, oh, Tom, when someone is about 17, 18 and they've got a mental health problem and they're 19, the services just fall to pieces because the CMHTs and mental health services aren't very good at 19-year-olds. And so we've developed what's called a transition service. It's mainly for children with neurodevelopmental disorders, ASD, ADHD, but also depression. And what happens is, rather than being discharged at 18, these young people can be moved into this service called the transition service, with a key worker still part of CAMS now up to the age of 25. Because many services now for young people go all the way to 25. We want to make sure that these children don't fall through the net and be lost. This transition service only started in April this year. And finally, I want to talk about ASD services, almost to reassure the audience. You'll have heard a lot about how the ASD services, autistic spectrum disorders services, might be changing in Wandsworth. The only change in Wandsworth I feel we will get is to improve the service. So we are reviewing the services, but only to make sure that parental support for these children is improved, the waiting time reduces, and the quality of assessment increases. So we're doing it at the moment. We're working with our parent groups to make sure our children with ASD in Wandsworth get the best possible service. Thank you.
Thank you very much, and thank you to my GP colleagues as well. Sarah, do you want to do the forward look now?
Okay, sorry, we've gone out of order. I'm sure that's fine. I'm sure you forgive us for that. So I'm going to talk to you about the plans that were developed across the country. It's actually, it says November 16 is when they were published, but actually they were developed quite a long time before that. They were called Sustainability and Transformation Plans. If you don't know what that is, I don't think it matters, and in fact probably isn't that important. I think what's important is that we're trying to deliver sustainability, high-class services for our local populations. But there was a national process to develop these plans at a kind of geographical area, and for us that was South West London. And it was a national process, and you might recognise them as the secret plans. They weren't intended to be secret from an NHS perspective, but there was a lot of issues about when they were published. However, we did publish a plan in South West London, and we've engaged on it and we've talked to people about the plan since that time. And we've listened to what people say, and what people have been saying to us is that actually we want more detail around the plan. We need to understand what that means for us locally. Actually, some of the assumptions that we made in there, we might need to reassess and review and make sure they still hold true. A lot of people said to me, whenever I went into a meeting, they would say two questions. Are you going to shut a hospital, and are you going to shut 44% of our hospital beds? And the answer to both of those is no, because actually we need all of our hospital sites. We may need to look at services and change them, but we need all the hospital sites. And actually we might need to use the beds differently, but I can't see a time when we can shut 44% of our beds. So people that don't know the plan may not recognise that, but those that have been involved will. But the most important thing, I think, is how do we take what was a lot of very good ideas worked on together across the system into something that's much more detailed and very locally focused. So people said to us, actually, this is quite top down, and we need to own this locally, and we need to develop this locally. So what we're trying to do now is we're refreshing the work that we have done, and we're saying, actually, we're going to take a really local focus on this. Now, local can mean anything. It can mean anything from kind of small communities of 30 to 50,000 people right up to sort of London even, because you could say particularly for the NHS, for specialist services, even nationally for some. We need to get the right scale, but actually locally you've seen the fantastic work that Wandsworth is doing with the local authorities, with the local populations, with the local voluntary sectors. Actually, we need to build on that. So we are also wanting to include our hospital trusts. So we have set up local health and care partnerships that include our local authorities, that include our clinical leads, that include members of the public, to help us to develop the next stage of the plans. For those of you that didn't see it, and I know Tom did because he was there and presenting, the Mayor has recently reviewed the plans for London and came out with some very clear messages around whether or not they were credible, these plans, and whether or not we could be delivering what we said within those plans. So this is our opportunity to make sure those plans are real and that they can deliver for us in South West London. It's really important that we do the bottom-up planning and that we work with councils So regardless of what kind of geography we set up around this, it has to include everyone. So we do have local networks where GPs are working with local community groups, with the voluntary sector, with the local authority, and then we have borough level stuff where we're looking at integrating health and social care services, and we need to make sure all of those work together with acute services, with acute hospital services, to make sure that they're both high quality but also affordable for our local population. So we're reassessing what we're saying about our plan, and these are the messages that we've heard from people, and these are the messages that we're trying to play back to you. So first of all, a local approach works best for health and care. So when we're planning, we need to take heed of what you're saying to us and work in a local way. Secondly, best bed is your own bed. Sometimes that's in your own home, sometimes that might be in a care home, but actually we want you to live independently and outside of hospital. Care is better when it's centred around a person and not an organisation. I think all of our clinicians would say they focus on the person in front of them, not on the organisation that they belong to, and we need to get better at that across health, social care, voluntary sector in order to support local people. Just by me saying it, we're not going to shut a hospital, it doesn't mean that all services will remain the same. We need to look very closely at the services we deliver, make sure they're clinically viable, we've got enough people to deliver those services as demand increases, make sure we have enough money to deliver those services. But what we are saying to you is, if we are going to change those services, we will come and talk to you, we will consult with you if there's any significant change on that, and we will make sure there's a really good case to make any change that we make. We also need to show people how it works better. We're incredibly good in the NHS saying this is what it's going to look like in 10 years time, please trust me, it's going to be absolutely fine, I'm going to change all your services and it will look great, but I'm not going to do it right now. But actually all the evidence that we've seen today shows where we have made a real difference and where we can do things differently, and there's lots of evidence out there, there's lots of people doing this stuff, not just in London, outside of London, and we need to take all that best practice and show people what we can do if we get it right. And key to this is that we need to involve people in that. We've got a really good record in Wandsworth of kind of involving people in everything that you do, and actually we need to co-produce some of what we need to do for our local populations. So I was going to then give you a really good example of where we're doing something well, but I'm not going to, because you've already done it, so I don't need to, and I think it's always better coming from the clinicians. So, involving local people. So we have actually done a lot of work in South West London. Some of it good, some of it bad. I'm not going to say that it's all good. We definitely take it very seriously in the NHS that we want to involve people. We don't always get that right. We've done a number of events across South West London. We've involved, I think it's over 5,000 people in talking about healthcare services in South West London. We've now got some reports on that, and what we're going to do is we're going to feed that information into the local partnerships that we're setting up so that they can start to build on what you're saying to us. But we don't want to stop there, we want to work with you to develop our plans for the future. So we need to get, do even more engagement with you in order to make sure that any changes that we make, that we are consulting with you, but also that you can tell us what you need and want from your local services. So lots of good work already going on in Wandsworth on that, but we want to try and always do better in that area. So I think it's you, Nicole. I was told I had 5 minutes. So.
Well done everyone for keeping to time, thank you. So yes, thanks very much team. I hope that what we've achieved this afternoon is a demonstration of the work that we've been doing in the CCG in the past year. We're really trying to make sure people in Wandsworth get the healthcare that they need. It's clearly a very challenging environment for us, and next year is going to be even more difficult, but we're working hard and creatively where we can, breaking new ground all the time in our efforts to find ways to do things better. So I think what remains is for me to thank my board and the CCG staff team for their efforts during the year. Thanks to patients and people in Wandsworth for your continued interest and involvement in the work that we do. Thank you to our partners in the NHS and beyond who support us, and finally to the GP membership of the CCG who remain engaged and committed to our NHS. Thank you very much. So I think we have some time for some questions. So have we got someone with a roving mic? Sarah is going to do the next. Yeah, because someone rove.
Oh, we've got two.
Oh, okay.
You take that one. And I'll take that one. Thank you.
I'm Peter Weiner. I chair the Heathbridge PPG. I was just wondering, with a very interesting presentation and the summary report, is this going to be available in soft copy so I can send it to the members of my group?
Chan, answer to that, yes. And where can people get those?
So Peter, everyone that's registered, I'm happy to email it out after the event. If you haven't registered, please come and see me, and I'll register.
I think what we'll do is we'll make sure it's on the website. It's the annual report, so we can do that. So I think if we'll email it, but we'll also make sure it's on the website so people can access it.
Okay, thank you for that.
Nicola,
Hi, hello, Matt.
can I just say well done again for another challenging year. And one of the things that's consistent about the NHS is the amount of change that happens, and the last year was difficult, and well done.
Thank you.
For marshalling all of that. We've heard a lot around about parity of esteem. I was interested in James's figures earlier on in terms of how much money and resources is actually going into mental health compared to physical health. And we heard a lot in the presentations about mental health and psychological therapies. And I had a conversation this morning about 75% of the people who need mental health interventions are actually not getting them. So what is the parity of esteem equation, and are we achieving that? Because I'm unclear about that. But also, how are we going to go beyond just an IAP service and actually reach those hidden, isolated communities that we're not currently reaching?
So is there a bit of a money question in there and a bit of a how question? So Tom, you'll perhaps do the how a bit in a second, but Sarah, do you want to do the finance?
The requirement of CCGs around parity of esteem is that when we get growth, so annually we get a level of growth, so we get a percentage growth, and that we must put that level of growth into mental health services as well. So what we've got to do is whatever percentage growth we get as a CCG, we have to put that equivalent percentage growth into mental health services as far as the money is concerned.
And we do. And we do. Yeah. And so, and because where's Neil? Neil makes sure that, I say, where's my 46 pence? I make sure every single penny that we're meant to be allocated, Neil very kindly makes sure we get it allocated. So we aren't one of the CCGs who doesn't do that. And regarding the IAPT, and how do we extend the service? So for psychological services anyway, so we're increasing the percentage of patients who'll get it this year anyway, from about 6,500 to about 7,500, and that will increase every year for the next 4 years. We're also working with the trust. We had a meeting which John chaired only on Friday, just looking at how can we make sure we do all the things you suggested. How do we get our hard to reach groups? How do we make sure we use different modalities? Because a lot of people would like Skype-based counselling. You can do it in the evenings, you can do it weekends, you can do it, without having to disturb your work. So we're really trying to push to make sure the Mental Health Trust has an expanding Skype-based services. How do we make sure we get people who don't speak English as a first language have proper effective counselling without an interpreter sitting next to you, which is not very helpful? And we're getting them to make sure they start offering counselling in Wandsworth's common languages. So we are taking it seriously on board, and we do have a clinical reference group which met on Tuesday, which John's from the service user group attends as well. Many patients reps come as well to really push the trust to make sure we are extending our counselling services.
Thank you.
Hello. I lived in Wandsworth for the past 20 years and worked as a district nurse, and now I'm still providing care. But the question is, I was in St. George's last night from 6 o'clock to 2 o'clock when we moved to Richmond Ward, and it's just evidence that the problem is, like short of staffing, area also, the space. We were told actually to move from the little cubicle to the corridor, where my sister had a big fall and she had a very, fracture of metaphyseal and she couldn't even move. And still we've been told to move because they need to use that room. And it's just, I love NHS and I love St. George's, and I worked as a district nurse for St. George's. But the problem was very clear, short staffed, space, and also she was cannulated sort of like 6 o'clock, and the first fluid she had was 2 o'clock in the morning. And it's not, fair for the patient to go through with a lot of pain. And when she go to the Richmond ward, she had the first coding, and she didn't have. And a few times I came out to say, we really need somebody to come in. But the support was there, the help was there, but it's just the connection between the doctor and the nurses. So it wasn't there. So we've been told, okay, you're waiting for X-ray. We have to wait 3 hours for X-ray. And it's, it's not good. And we have a beautiful hospital in Queen Mary's, and it's becoming a rehabilitation centre. And we were just thinking, and I live in Roehampton, opposite Queen Mary's, and I'm thinking we should be using Queen Mary's instead of St. George's, while the St. George's is getting, all the support it needs.
Yeah, okay, thank you. Lots of bits and pieces in that question. I'll ask Sarah to talk about the Queen Mary's angle of that in a moment. But if I could just say, so lots of people feel like you about St. George's. We really want it to function well for our patients. We all really do. And there are many people working very hard to try and achieve that. I'm sorry you had such a difficult experience like that, and I think if you want to write that down to me, that it's very helpful for us to be able to record these things so that we can use them to try and improve. But it's really good to hear it here today, because I think many people don't get the opportunity to tell us so clearly about what's happened. We were really ambitious for George's. They've been through a very, very difficult few years, and they've got a new leadership team in place who are very focused on trying to improve. Quality of care and safety are our absolute prime concerns in the CCG, and we have been doing everything that we can to support the new team in trying to make the improvements that they need to make, to address the Care Quality Commission plan that they have to do in order to be approved as a good or an outstanding hospital in the future. And we've got lots of additional oversight. That's our role as a CCG, to try and assure ourselves that St. George's is doing all the right things. We're working closely with their clinicians. We meet regularly with the doctors and the nurses who are working at St. George's to try and make sure we put the practical things in place to help them, and also to do the work out in the community and primary care and the community services, which we need to get right in order that the hospital can do its job better. So there's a vast amount of work going on with that. I think it's not good enough. We would want St. George's to achieve all of the standards and performance targets that we have for it, but really it's about the patient experience and making sure care is a high quality and safe. So thank you very much for sharing that with us. The issue of Queen Mary's, Sarah, do you just want to outline what we're thinking?
So we agree with you on Queen Mary's. Absolutely, it's a fantastic resource and we need to use it better. So I think that's the kind of bottom line. I think that what we need to do now, we're working with St George's and with other hospitals, so Kingston also delivers services from that unit, and with the members of the CCG and the local public to try and develop a clear understanding of what we want for those services, because I think at the moment it's become just a group of services together rather than a real kind of unit that works with a clear strategic aim, and we know what it is that it's trying to deliver and getting the very best services that we can onto that site. So we're going to be working with all the hospitals, with the clinicians, with local people to develop that and to implement that as quickly as possible. So it's going to be a real focus over the next sort of 12 months.
Got a lady here. I'm just going to mic for you. Thank you.
Hello.
Hello everyone. My name is Elizabeth Partingamanu, founder of Aspire to Inspire Dyslexia. My question goes to the gentleman that kind of rode in.
Dr. Randall.
When Tom was speaking, he mentioned support and help for people with specific learning difficulties, i.e. autism, ASD. I didn't hear dyslexia. We are an organisation in Wandsworth. These conditions are overlapping: dyslexia, ASD, autism, and all those other conditions, hidden conditions that, you know, not physical, you can't see. We have lots of clients that come to see us with mental health issues, with anxiety, with panic attack, and all those that go with it. And it'd be really interesting if to see anything that's been done for dyslexic children and adults in the community.
Okay. Just very quickly, so we are just in the midst of a review, and I'm talking about mainly ASD and children, and we're trying to get as much community input as possible. So if I can get your email, and then, so what parents have said to us is that getting a diagnosis isn't as important as getting the support. Yeah, often we need people, and it's not just waiting for the diagnosis as a post-diagnostic support, but throughout the child's education and learning. So maybe if you give me your email, and I can make sure you're involved, your organisation is involved, as we're consulting on the right model for these children.
Absolutely, because what I wanted to say was, just to add to that, it's not actually dyslexia it's not dyslexia that's the issue, it's the repercussion of dyslexia.
Yeah.
Sometimes.
Yeah.
Yeah. Thank you.
Hi, my name is Vanessa Bob. I run a charity called The Second Voice, supporting families with autism. My problem I'm having is that I was part of one of the Seldom grants, and I noticed in there doesn't say what you find. A lot of autistic adults in particular don't have to be put under learning disabilities. So that's something that needs to be addressed as well. That's one. I know in regards to Liz, when she spoke about dyslexia, a lot of people with dyslexia don't like white backgrounds, which is something that needs to be looked at as well. But the thing I wanted to talk about with regards to my problem is that I've got a son who's autistic. It took me 9 years to fight Wandsworth Council. But my thing, what I'm going to talk about is the sibling, that my daughter ran away 2.5 years ago, but I had to fight the system because people don't understand what autism is when it comes to the family. But what happened with me, my daughter actually came home in June for graduation, but I had to deliver my grandson 8 days ago because when I dialed 999, I didn't realise that you're not meant to call the services. So I think when it comes to women that are pregnant, but especially teens, my daughter's 16, I think it needs to be more clearer because they told me they couldn't help her, but I didn't have to call her back when her waters broke. But for me, it was trauma when I had to actually deliver my grandson. Because when I look back, it was a horrible experience because her eyes were rolling, I didn't know what to do. I had my autistic son, very hysterical. And then my 11-year-old, obviously, to see the birth, I just realised that there's not a lot when it comes to teen pregnancies. Something that I don't condone, but because she had the child at home, and then to look in the red book, actually put that she was born in the hospital. So I think there's a lot of lack of communication when it comes to services. That's something I want to address for teen pregnancies and those who've got learning difficulties. And she's got moderate language difficulties. Again, I don't know what that means. So it shows there's a language barrier with everybody.
Yeah. Okay. Thank you. I think we will take that and pick up on the issue of quite a specific group of people that you're talking about who might need additional support in the system, and I think it's important that we recognise that. Thank you very much. Who's got a gentleman here? Okay.
Can you hear me, or do I need the mic?
Please use it for other people.
Okay. Yeah, my name's Mike Squires. It's a question about St George's. St George's 2 years ago ended the year 73 million overdrawn. 50 million overdrawn. Last year it's 73 million. And the latest finances at St George's are in a perilous state. They started out with a projection of 28 million being overdrawn. They're already back a quarter of the way through the financial year. They've had to go back to NHS improvement and say, look, we think we're going to finish the year 45 million overdrawn. My guess is, looking at their financial papers, it's going to be more like 80 million overdrawn. So they're in a perilous state. And the second thing is, what's really going to push them over the tip is, of course, they're never meeting their A&E targets of 4 hours turnaround now. If an accident and emergency department was to close in one of South West London's hospitals, it would be absolutely overwhelming for St George's. So I know we're going to get the backing of Wandsworth Clinical Commissioning Group to ensure that no A&Es which close in the area, because our local hospitals would just be overwhelmed. And my second question is a broader one, that we spoke a lot about STPs, which everybody knows about, but of course STPs are history. They're no longer with us. That the NHS is now going over to what they call accountable care systems. So you have big insurance companies running your local healthcare, like Kaiser Permanente in the United States. So we're into some big changes. And as a projection, I mean, I'm 75. I'm lucky in a way. In 10 years' time, there will not be an NHS. It will be broken up and privatised. The poor won't get any cover, and everyone else will have to be expensive insurance premiums.
So, thank you for those views. Did you have a question, Dr. Squires?
Oh, yeah, absolutely. You got around knitting.
I'll give some of it a go. How about that? Great. Firstly, we very seldom shut A&E departments. We avoid that at all costs. We do have a number of ways in which we do that across London. We work with London Ambulance Service. They have what they call intelligent conveyancing. And what that means is that when ambulances, when you get too many ambulances at one trust, they kind of slightly divert them at the edges to other hospitals so that they don't get overwhelmed. There are instances where we shut A&E departments. Usually it's because we have had some kind of failure, some kind of electronic failure or something happens that means they actually cannot carry on. It's very seldom that an A&E department will say we're actually closing. When that happens, we do have protocols that allow us to divert people across the whole of London if necessary and out into the Surrey and Kent as well. So we do have protocols and we do manage that very well in the NHS. I am not suggesting that all of our services are not under pressure, absolutely they are, and we will be working as hard as we can with all of our providers across the winter time to make sure we're in absolutely the best place we possibly can be to avoid anything going wrong.
So just unpicking Dr. Squire's question, I think you might have been talking about a permanent closure of an A&E department.
Yeah, in South West London.
Okay, well, there's going to be no permanent closures of any A&E departments in South West London for at least in the next 5 years, because we know that, because there is no plans in place, and that's how long it would take to do something. So this winter, you're absolutely safe, and that will not be happening. If we ever did decide to change any A&E departments, we'd have to be able to evidence that we can cope with that, and that we have all the mitigating factors in place in order to manage that. And at the moment, we don't have a proposal around that, so that's where we are on that. I'm glad you've got your crystal ball. I have no idea what the future political climate will be around the NHS or what that might mean. I think what's important to us, it doesn't matter whether it's got an acronym called an STP or an ACS or anything else, it has to be about what are we trying to do together to deliver the best possible services for our local populations, and how do we manage the demand efficiently so that we can continue to deliver the high quality services that we currently do. And I'm not going to comment on the politics.
Yeah, good, thank you. I think we've got time for one more question.
Thank you. Thank you, Nicola. Picking up on Mike's point about SDPs and the financial situation facing South West London, as I understand it, SDPs aren't entirely dead. As I understand it, they're still sort of struggling along. But one of the elements of SDPs which you haven't raised, and it was quite interesting that you focused on services rather than finances. My understanding is that across South West London, across the SDPs in South West London, the providers and the commissioners had to make a saving of £1 billion by 2021 on their current spending, and they're eyes water because they don't actually know how to achieve this. So how is this saving going to be achieved?
So it's all about the money again, sorry. James, I think we need to...
You answered the easy question about mental health parity.
Yeah.
So it's an interesting question, and one I'll wrestle with every day. When STPs were set up last year and when they were created, you're right, everybody was tasked with this equation of can you work out how bad the gap is if you sit around and do nothing and let populations grow and use services they do. And we calculated a figure of 900 million for that across South West London. I wasn't involved in that calculation, but I was involved in another one in somewhere else in the country. So I know how those have been built up. And then, as you say, what we were asked to do as part of the challenge was to say, how do you then save that money so that you're sustainable in 5 years? As ever, we were asked to do that over a 5-year period, and then when it came to the operational plan, they were actually set us the challenge of how do you balance next year, which is far more of a greater challenge. In reality, what tends to happen, you could go back over the NHS over the previous 5 years and the previous 5 years over that, and we will have made a lot of changes and saved a lot of money. And what we don't do, as you've heard today, is actually sit around for 5 years and let a problem develop. Sarah talked there about how we're refreshing the STP, and as part of that, we'll be refreshing the financial equation that has to go right behind that, and we'll then develop that around the clinical models that are being developed within each of the systems. I think the things that we're doing a little bit differently on that is, A, we are looking at it on a granular annual basis. Yes, you need to have an eye on the longer term, but we're actually looking at how we deliver on a, well, it feels like a day-by-day, week-by-week basis at the moment, but certainly on an annual basis we're looking at. The other crucial thing that we're doing is we're doing that on a bottom-up basis. So we're looking at doing that on a system basis. So I think Sarah talked about earlier, we've set up local transformation boards, which will be very much looking at this, how you work across within a subsystem within South West London, and we're doing that, trying to do that with a very different dialogue around how we have that conversation between different elements of just both the NHS and social services and the local authorities as well. So that what you're actually trying to focus on is to less around some of the transactional stuff that the NHS has become a little bit embroiled with, and moving much better to how we look at things collaboratively and how we can change the way we provide services across the system. There's no doubt it's a challenge. As you've now picked up in the press recently, we're starting to see the pay freeze in the public sector is starting to slip, and that will create another pressure, welcome though it is for the staff who have had their pay frozen for a while, but that will create financial pressure. But that's the way we're working up, and it has to be done. The financial equation you have to do alongside the clinical models, because that way you can try and answer both of the equations.
Can I just add to that? I mean, we're never going to say no to more money, because we do need more money in the NHS, we all recognise that, but what we're currently doing is we're not getting less money in the NHS every year, but what we are doing is we're trying to keep up with inflation and pay increases and additional demand. So what it is how do we manage more effectively as we move forward? I think a lot of people assume that what we're actually doing is getting cuts. Well, you could say in real terms maybe we are, but actually what we're getting is lots of additional demand and increased costs for the same money, or just a little bit more. And it's about how do we manage that. So it's not about cutting everything, it's about how do we deliver things differently for the resources that we have. I don't know how long we can carry on as we are without it actually tipping, but we are going to do, what I can't say is that we're doing everything we absolutely possibly should at the moment. There is still more efficiencies to be gained in the system, and we need to get absolutely the best we can from our systems, and we need to support people as best we can from both the NHS and from the local authority.
Okay, thank you. So just a quick reflection on that really is, I think, so I've been chair for 6 years now, and one of the things I've realised is that there's quite a lot that I can't control. So I can't control how much money we get, and I can't control the politics, and I can't control the things that we're required to do by the Department of Health and NHS England. What I can do is every day try and do the right thing to make sure that people get the care that they need, and that's what this team and my team of clinicians are really focused on. And the money is vast in that. It's, of course, it's really important in the equation, but I think what we're driven to do and why we're driven to do it is because actually people like you are needing care, and what we want to do is just deliver the best we can and make a difference to people's lives. So that's my speech over. Ladies and gentlemen, thank you so much for coming today. I can't believe that you all turn out to come and help us to do what we have to do. We are really grateful for your presence here today. And there's tea and coffee down the end, and go and have a chat, and we'll come and talk to you, and you get the opportunity to ask us some more questions if you need to. I'd like to give you a round of applause for coming today. Thank you. We've got some evaluation forms. If anybody would like to fill one in to tell us how we did today, it would be much appreciated.